Hearing none, if we're ready to vote, Nora, if you'll run through the roll call for us again, please.
Certainly. Dr. Drake,
Yes.
Dr. Gutcher,
Yes?
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. Ryan,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
Ms. Wagner,
Yes.
passed unanimously. Thank you.
So we have the agenda modified ×2, and any other discussion on the agenda items? If not, we'll get a motion in a second and get the agenda approved.
I'll motion to approve.
In a second,
I second it.
any discussion? If not,
I have one discussion. Make sure that what we just said for Dr. Shumi would be second right after the.
that would be the plan.
Just want to make sure.
Yes, sir. Yes, sir. Any other discussion? If not, if you're ready to vote, Narda, if you'll run through a quick roll call for us one more time.
Okay. Dr. Drake,
Yes.
Dr. Gutcher,
Yes?
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
Ms. Wagner,
Yes.
9-0, passed unanimously. Thank you.
Thank you. You have set the agenda for this evening's meeting. So as amended, the first item is going to be the public forum discussion. And when I went over this earlier this week, the discussion, I think, was going to be centered on when to have a public forum. It wasn't going to be a public forum this evening, but when to have a public forum. And Mayor Jacobs, did you have some information you wanted to share with us or help us along in that discussion?
No, sir. I just, whatever decision this board makes, I think next week was a scheduled public forum, if I'm correct. And of course, a lot of this is up to you as chair, Dr. Gocher. But whatever the board decides how you all would like to do public forum, we can accommodate that. My staff can. We just need to know what everybody wants to do.
Okay. I don't have our rules right in front of me, but I believe our rules call for a public forum once a month. And I'm trying to remember when our last one was. These all blend together, but I think it was about 3 weeks ago. So this would be, next week would be, that 1 month period. Is everybody sort of in agreement that that was the schedule we were on?
Do you guys want us to pull them up, but I believe that is the correct answer, Dr. Gosher,
Yeah.
but we can pull them up if you want us to.
Yeah, that'd be fine just to verify that, Charity.
Okay.
So we're due for a public forum. And so the question would be when in the meeting to have it. I think we've had it before our regular deliberations, starting at 5 and then completing the deliberations afterwards. Total of 30 minutes would be allocated, first come, first served basis, as you can read for yourself here.
So, Dr. Gocher, the only thing I would add, and pending the next discussion we're going to have, is that, and of course, not knowing how that's going to go, is that in the event we changed our meeting schedule at all, it would, be our next meeting. Right now, the plan is our next meeting be next week, but that's the whole intent of the next agenda item. So,
Right. But as it stands now, we would be preparing for a public forum in 1 week. And again, we have looked at it as appearing for 3-minute periods, total of 30 minutes, first come, first served basis. And as you know, the governor has extended through the month of October, at least October 28th, the option for Zoom meetings. So I would assume we would continue Zoom meetings up to that point. And we have, I think, been able to engineer something pretty acceptable in terms of the public forum via Zoom. And I think we could do that. So provided that we don't change anything, it would be next week. And again, this is really for information at this point. Any discussion or any comments about the public discussion forum? So again, for discussion only, we're looking, if we keep our pace for meetings, it would be next week. Any other discussion on that item of the agenda? And just really for information at this point. None? Charity says that there's some difficulty hearing me. Am I coming through okay? Everybody hear me okay?
Yes, I do.
Okay. I don't know.
Yes, I can hear you, sir.
Okay. So if there's no other discussion, we'll go on to the next item of the agenda, which was meeting frequency. And so this was brought up by Dr. Shamiya. So Dr. Shamiya, you have the floor if you want to initiate discussion on that.
Thank you. So I brought this up more than once. I'm the original reason, at least I brought up originally, us transitioning to a weekly schedule of meeting. And then I think in one other meeting, I at least raised the possibility of us extending from weekly to every 2 weeks. I think part of my thought process behind this, there's a few things. One is that and I wanted to do this early in part for two reasons. One is I didn't want it to seem like a reaction to how the meeting went and the decisions that were made. Secondly, just understanding COVID-19. I don't know what type of regulation or otherwise that we would put in place that would be in existence for less than 2 weeks. It just doesn't make scientific sense that that would be the case. I think that certainly this has been an opportunity to educate and convey information, but the health department is also conveying that information. And I think that as we've now been at this for a period of months, just simply to be properly prepared for this, the churn of every week versus every two. I mean, there's multiple reasons why I think that would potentially make sense. But primarily, well, and then I've learned more about government. It's been a civics lesson across the board, but there really isn't anyone meeting every week other than the way we're doing it. But I think fundamentally and most importantly, it has to do with the fact that anything that is going to require action, I think, can be viewed at 2 week intervals. And so, I mean, if the group still wants to meet weekly, I'm certainly at peace with that. But since, again, I'm the one that was the impetus for us meeting once a week, I thought I would be potentially the appropriate person to raise the possibility of us meeting once every 2 weeks on Wednesday night. And so, I don't think we've ever conducted this as a motion and a second and all those kind of things. I think it's generally been consensus discussion, but Dr. Kocher, whichever way you care to proceed in this is fine with me.
So, I'll kind of leave this maybe at the will of the board, but one way we can do this, and sometimes in meetings, you can have a brief period of general discussion followed by a motion, a second, and then, more formal discussion of it. Or we can go right to a motion in a second and have formal discussion. Any way you guys want to do it.
Let's just talk.
Okay, we'll do that for a few minutes because, it's kind of really, it's not well directed, but we can do that. That'll work, Dr. O'Brien. Discussion about this?
So I agree with Dr. Shamiya. I was actually considering bringing this up this evening as well, and he beat me to it. I think that from week to week, we're probably not doing that many changes. And as he said, most of our policies are at about 2 week intervals for the most part. So I think it makes sense for policy wise, as well as he mentioned that we've been going every single week since the beginning of June. It's a lot of work.
Any other general discussion? Would anybody care at some point to make a motion in a second on this?
I make a motion that we go to by week or by every 2 weeks to have our Board of Health meeting.
Is there a second?
I'll second that.
So we have a motion and a second. Further discussion? Mayor Jacobs, how does this work as far as the county and setting things up? Is there any problem that you see either officially or unofficially in going to every other week?
No, nothing changes.
Okay.
Dr. Gotcher, for clarity's sake, for minute taking, are we saying that that would start, so we would skip next week and it would start the following week in this discussion?
That we can do, that would probably, that'd be what would be implied, is that next week's meeting, which would be that public forum, would be moved back 1 week.
Okay. Thank you.
You could do it either way. You could have one more weekly meeting, but I sense if this is voted in the affirmative, it would start today and the next meeting would be 2 weeks down the line. Any other discussion on the motion to go to every other week schedules? Negatives, positives, controversies, anything? Okay, hearing none, I sense we're ready to vote. So Narda, if you'll give us a roll call one more time.
Yes, sir. Dr. Drake,
Yes.
Dr. Gotcher,
Yes?
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes, and Dr. Goetzer, I have to leave after this vote. Thank you.
Okay, we appreciate your input, Mayor Jacobs. Thank you for attending.
Thank you.
Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Souza,
Yes.
Ms. Wagner,
Yes.
passed unanimously. Thank you. 9-0.
Dr. Goetzer, you're off.
Sorry. We have then passed to every other week scheduling, and we will set up that public forum at that next meeting, which would be in 2 weeks then. So we, need to let the mayor's office know, since they very graciously assist us with that.
And that date is October 14th.
Yes. Okay, very good. So now going to what was written as point 6 in the agenda, which is Knox County Health Department benchmark presentation. And Ms. Menifee, if you will kindly give us this week's report.
Yes, sir. Happy to do so. I'll start with our local situation as always. Today we have 57 new confirmed cases since yesterday's report. That's giving us 9,885 confirmed cases since March. We have 429 probable cases. We have 8,714 of our cases are considered inactive, with 1,516 active cases. 369 Knox County residents have been hospitalized at some point in their illness, with 36 currently hospitalized. And unfortunately, we do have an additional death to report today, and that raises our total to 84. A note, actually, can you leave it there real quick, Catherine? A note for something that's coming tomorrow, and this might be something that's been noticed. We were seeing that our data, between our data and the state's data, there had been some discrepancies on our case numbers recently. And there's always been some of that, again, with when we get our data versus they do, and cleaning things out and all of those things. But we were seeing it growing, and we're getting concerned and started really diving into it. Realized and spoke with the state, and the state is doing some amazing work. They're actually geocoding all of their cases, which allows them to do a lot of fancy things. But the issue that we're running into with them, and we'll be discussing more, is that doesn't get the cases that maybe don't have an address but are living in a home address, quote unquote, but are living in our jurisdiction. I'm going to say the university students are the best example of this, and probably the largest example of this. And so they're assigned to our jurisdiction based on that they're living here, they're part of our disease burden, we're working the cases, they're impacting our community. The state agrees with that, and that's why our numbers are showing, are growing and showing higher than what theirs is showing. And so want you to know you're going to start seeing a change tomorrow in our data, because what we realized with that, though, is that when we were doing the SAS coding, when you have 10,000 plus records, and those are just the positives plus all the negatives, and you're looking at everything, the SAS code that we use to pull our data has to be used. We're not doing that by hand, obviously. The code that was being used was based on the geocoded data from the state and not the jurisdictional data from the state. We didn't realize that at first. And so tomorrow that's going to be fixed. It's going to be now the inactive and active cases will be based on our jurisdictional data, which is the true data. So you'll see a little shift there tomorrow. So I just wanted to make you guys aware of that if you see it, so you know it's coming. Any questions on that? Because I have Roberta Sturm, our lead epi, who could probably explain it better than me on the call tonight if you have more questions before we moved into the benchmarks. Nope. All righty, we'll go on down to the benchmarks. The first one, go ahead.
Sorry, just real quick. So we're saying that it's going to kind of be a reset, like tomorrow's data is it'll just have all that fixed, or what exactly?
Yeah, tomorrow's data you'll see, and Bert, are you there where you can speak up?
Yeah, I'm here.
Go ahead. I'm going to let her explain.
All right, so there's going to be a shift in data. So there's going to be those individuals that, have quarantined here or have been isolated here, but may have an address somewhere else. So based on whether or not their case status is recovered or active, that number is going to shift a little bit. I don't imagine that it's going to be too extreme. But it's not really a reset. It's more of just making sure that we have all the pieces in there.
So, and I want to stress on this, our case count number is the accurate number. This is, and that you're not going to see a big change there, correct, Bert? This is just in the inactive and active, because we weren't pulling, if they weren't geocoded into our jurisdiction, they weren't being counted in that number totally. And so we're just making sure we're getting that correct.
That's
right?
correct. That's the only part that's going to change. But our case count, our probable count, that is correct.
Thank you.
All right, so moving into the first benchmark, the sustained reduction or stability in new cases for 14 days. In the last 14 days, we've only seen one yellow flag. We have received an average of 77.9 cases over the past 7 days and an average of 87.8 cases over the past 14 days. So the case numbers do appear to be heading in the right direction. We'll talk about some of the concerns along with that later, but on this front, it's a good sign. And because of that, we are representing this benchmark as green. It's not a Grinch mark, I guess, it's a benchmark. Our second benchmark is community-wide sustained and increased diagnostic testing with consistent or decreased test resulting turnaround time. Over the 14-day evaluation period, we had one red flag noted for lab turnaround time. However, since mid-August, the lag time has decreased and the turnaround time is consistently around 2.5 days. Regarding testing, however, we did have 5 red flags and 1 yellow flag. The red flags are generally, we see them on the weekends when testing isn't as widely available. I mentioned this last week. And since August 1st, the number of tests conducted has continued to decrease. But the average testing volume has remained above about the 4,000 mark, but it's still not trending in the direction that we want it to go. We would like to see that moving back up instead of down, because it makes it really harder to have a good picture of what's happening in the community, when we don't have the testing volume as it had been before. Because of that, we're representing this one as this benchmark is yellow, and it's the same rationale as last week on that. Our third benchmark, sustained or increased public health capability. For this one, we aim to initiate investigations for new cases within 24 hours and close contacts within 48 hours. We have added some new folks to our team again. This is really all about trying to get our KCHD permanent team back to their work as much as possible, but they're still available to help, which is why you see that number growing. despite the number of cases we have. So that's our team that we can pull from right now that's trained and ready to go. And so we represent that as green. Our fourth benchmark is the healthcare system capabilities remain within current and forecasted surge capacity. During this time frame, we saw 1 yellow flag followed by 3 consecutive red flags for hospitalized COVID patients. We did see 1 yellow flag for ICU patients and 4 red flags for ventilated patients, but they were not on consecutive days. And after speaking with our hospital partners, and Dr. Shamiya will go into his data much more, I know they stated that their benchmark should stay at a yellow. And then our fifth benchmark is sustained or decreased COVID-related death rate for identified positive and probable cases. Over the past 2 weeks, we've seen 11 deaths within 5 in the last 7 days. This information, the information available continues to lead us to represent this benchmark as yellow. And then 2 more things that we added real quick that aren't really in the benchmarks, but we wanted to have available for your discussion points and for the public. And you guys had asked for this and this information. So the first chart shows new COVID daily cases per 100,000 population. On this graph, we'll show you the 7-day and the 14-day trend line. As of today, we are at 12 cases per 100,000 and people. And then the second chart shows the percent positive. This is data we're pulling directly from the Tennessee Department of Health data. I want to make sure that's clear. So they're not the denominator we're using here. And the numerator actually is straight from TDH data. So that way they had all the back data for this, and we wanted to be able to keep it consistent. Our daily positivity rate as of Sunday, which was the last day we were able to pull it, is 6.92%. We also depict a 7-day trend line on this graph as well. So any questions on any of the information that we have for you today? Happy to try to answer them.
Questions, discussion? I have a question for board members that can sort of lend a hand and maybe help me understand this a little bit. So the sort of the benchmark testing we use is RNA PCR, and is this a test that is primarily used for diagnosis or for surveillance? And what are any advantages or disadvantages of using it as a surveillance tool?
Do you want me to start and then I can let somebody else chime in?
Yeah, general discussion.
Okay. The PCR is what we have right now is the gold standard test for the diagnostic side. And that's the only way to have actually a confirmed case according to the Tennessee case definition. It has to be a PCR positive. I am not aware and have not heard of any concerns or issues with using it as surveillance data. For all of the other diseases that we use, we tend to use the gold standard test for whatever that is for our surveillance data. And so the question that we get frequently is then changing, and you're going to see more antigen testing coming. Just to hit that off, there's obviously the antigen test kits and are being given to long-term care facilities and other places. For Tennessee, that case definition, if you're an antigen positive, would put you into a probable case. There are some more concerns there with whether the accuracy, especially if it's for an asymptomatic person versus a symptomatic person. And then the antibody testing is what, in all of the reading and guidance that I've seen from CDC and Tennessee Department of Health and World Health Organization, the antibody testing at this point in time really should be used for surveillance and not diagnostic testing. That's kind of the big overview if anybody wants to chime in.
Any other discussion on that? Any discussion on the benchmarks? If not, thank you very much for another really complete report. Appreciate your efforts.
Thank you, sir.
So next up is going to be on the agenda. It's going to be University of Tennessee Medical Center's data update with Dr. Shamiya. So Dr. Shamiya, you have the floor.
Thank you. So a few changes this week. I'll just wait till we get in present. There we go. And so just a few changes in the data and one new thing to discuss. So next slide, please. So this is our hospitalization correlation between cases and hospitalizations. This has really become remarkably stable over the last weeks. So we were at 36 per thousand, now we're at 35 and 41 to 40. But I think we'll be watching to see if this changes, but it hasn't really significantly budged for several weeks. So this enhances our ability to predict the future. Next slide, please. So as far as the pace of new cases, and again, I need to remember we have a new member with us, so try to make sure I've oriented. So on the left is going to be Knox County, and on the right is what's known as the THA Knoxville district, which is all of the counties in that box. So on the left, this is the same as last week. On the right, that far right-hand side, the 7 is new. So in other words, it took us initially in the district, it took us 81 days to get the first 1,000 cases. And then you see what's happened since then. And most recently, it took us 7 days to add the most recent 1,000 across all those counties. Next slide, please. So I've got a new little box there to go through, but first of all, just to talk about new cases by week and by month, you see in Knox County that we had dropped to some extent last week, and then a more significant drop this week at 572. I'll go in a little more detail by age, what I think is driving that on the next slide, but a significant drop. Then on the right, you see that September exceeded all other months in terms of new diagnosed COVID-19 cases. Then in the bottom, the Knoxville district saw drops, although not quite as dramatic in the most recent week. I will say that the drop in the district was driven by Knox County almost entirely. A point I'll make now in the upper left on that text box, and I'll have to clarify, I don't think this is what Charity was talking about during the beginning of her presentation, but one thing we've noticed over time, and there's a variety of factors for this, but there can be a discrepancy between what Knox County Health Department has as confirmed cases and what TDH has, and I've not totally understood. There's a lot of data going on behind the scenes as things become placed in the right category. But what we noticed is through the end of August, there was a 432 discrepancy in that. And now through the end of September, that's 628. So in other words, the percentage discrepancy or the amount of discrepancy as those cases are assigned or reassigned seems to be more. So we just don't know really what that means related to our current case counts, whether that in any way, it would seem that in the last 4 weeks or in the month of September, this discrepancy has widened on these positive cases, and we really don't totally understand why. All that's really, from my standpoint, doing is making sure that we're going to continue to watch this closely. Go ahead, Charity.
Oh, sorry. That is actually part of what I was talking about. So in our data, and the state has verified that we're counting the way we should as far as our local disease burden and all of those things. So most of that is that those differences are that they're assigned to our jurisdiction, but have likely an address outside of it or not in our jurisdiction, or that they don't have an address at all. And it's just because some people refuse to give one. But they're cases that we're working and counting, and that's what we're trying to work on. And then that led to where we were pulling our inactive and active data using that geocode data that they had instead of the jurisdictional data that we were using. So they are definitely combined, and we will continue talking with them. The issue is the geocoded data is allowing them to do a whole lot of different things for statewide pictures and assignments. And so I don't know how likely we'll be able to get that switched, but we did, and Bert can chime in here, did confirm with them that definitely what we are reporting is what is assigned and what we're working in our jurisdiction. and that's the disease burden for our community and the impact to our community and all of those things.
Okay,
That's.
go ahead, sorry.
I was just saying that I agree with Charity. That's correct.
Okay, great, thank you. So next slide, please. So we've shown this the last several weeks as far as the breakdown, and again, as the drop is driven by the 11 to 30 age group. I can say our experience is that our outpatient testing, our kind of treat and release testing has dropped, and it's dropped without question in these age groups. You see at the bottom, other than some degree in the last 3 weeks, not dramatic of an uptick in the 51 and older group, that most of the bottom row has been relatively stable. So the drop is very much, the increase and the drop seem to be very much driven by the 11 to 30 age group. Next slide, please. So I do want to park here just a minute. This is essentially just another way of showing one of the things that Charity showed. And what it shows is essentially a relatively stable testing volume, but then with just mathematically with fewer positive cases, your positivity rate is going to go down. This is a 70-day average, a slightly different number than what Charity showed. I guess what I'm not sure about on this is that the stability of this testing volume is, there's a disconnect between this and what we're seeing. And so I don't know exactly, we never, Dr. Buchanan mentioned multiple times that this probably doesn't represent all of the tests being done, but I guess as including some of the things I'm going to show you in the next few slides, the question we have to ask ourselves is this steady testing sample representative of the total sample, and who are these people? Are these people in screenings? Are these, hopefully we're capturing all the sick people being tested, but the stability and what we're sensing kind of day to day are not the same. Next slide, please. The big four, we call it the comparison in the counties. You see that Shelby and Davidson have been really relatively stable. Hamilton may be ever so slightly on an upswing, and then Knox is exactly what I just showed you. Next slide, please. Now, all this leads to the hospitalization, and this is where the next few slides, I think, as I get to census, you're going to see a little bit of a disconnect. So Knox County hospitalizations, these are new hospitalizations each week, have been very stable. You see on the right-hand side, 102 total with, and that actually doesn't complete, that was through September, through September 29th, hospitalizations, more than August at 68. The district shows relatively similar stability although a few weeks ago there was more of a steady increase from 34 to 53 to 52 to 59, and then has leveled at around 56. So the next slide is our hospital census. And again, this is the difference. That last slide was new hospitalizations. This is the number of people who are in the hospital on a given day through those counties. And this is subject to reporting issues. So what you see there is that we have had a spike up to 129 most recently. We've had spikes like that before. I can tell you that we felt this, we have a community capacity call, and our hospital seemed to feel this a little bit more than the other systems, just for whatever reason. They were a little more stable, although across the board there has been some degree of an uptick. But I put those dates there just so you could kind of see how the first time we increased, in 7 days, we went from 71 to 101, and then another 7 days, we went 101 to 130, and then another 7 days, 130 to 185. What we saw in a recent 7 days at our hospital was an increase from 18 to 37. So certainly nothing that is just unmanageable or overly dramatic, but we're going to need to see if that is an ongoing trend or not. Next slide, please. So consistent with that, these are the projections that I show, and the the last three trend lines. So the red was what I showed you last week. We were projecting at 94. The blue was the week before that at 110. And I've told you guys multiple times, what a difference a spike can make. But looks like the green there has got, based on this most recent growth, would have us on November 1st projecting at 173. So we'll just have to see where this goes and see if this was more just of a fluke, because we have had some up and down, or whether it's anything consistent. The timing after Labor Day, I've decided that you can't perfectly time or predict any of these things, but it would be in the general range that you might expect. Next slide, please. So I did want to, this is kind of just, I took this opportunity for a single slide because I do think that we need to use this opportunity to educate. And we've seen, we've started to become more interested in some of the other COVID effects other than just respiratory failure. And one of those things, and my point in this largely is to talk about where testing in the community fits into this, and is something called myocarditis. And I'm going to be very much clear that what is known and what is not known on this single slide. But the background is this is inflammation of the heart muscle, and it can cause sudden cardiac events during athletic play. And so this is some of what got attention in some of the collegiate divisions about with what they were making their decisions based on. That being said, COVID-19, there has been an association by MRI. MRI is a picture of the heart that can show this type of inflammation. I need to be very clear here that this isn't unique. It's not the only virus that can cause myocarditis. Other viruses can do this as well. And what they've started to report is that even in people who don't have symptoms otherwise can develop some signs of this type of inflammation. And just to be fair and clear, it is not well understood. But the concern is related, I think, to three factors. One is that it's poorly understood. And for those people who get it, are those effects that could last months or years. It certainly is being studied more than any other viral cause of myocarditis. So we're going to understand it better than any other viral cause. But as to its implications, we really don't know. I think that based on the high number of young people infected, it's kind of the scale thing, is that even if it affects a very low percentage of infected, if we have a lot of younger people infected, then the actual number of people it impacts could be real. And then, of course, it's whatever is the impact on the individual patient. And I bring this up not to, again, I've tried to be clear about how this is not well understood. So this is not intended to scare, but what it is intended to do is I'm sensing more and more that there's this idea in young people that it doesn't even matter if we know they had COVID or not, and that they're resilient, they'll get over it quickly, and they'll just get on. And this is an example of just how not well understood this viral illness is. And so with a lot of people infected, we could start seeing things like this. And it's more than anything else just to drive home the importance of testing, to know if someone had it or know if they didn't have it. Next slide, please. This is my final slide. So this would be my key points from today. This has been our lowest week over week amount of new cases since August the 16th. The decline in 11 to 30 explains almost all that variation. The positivity rate remains above recommended thresholds. And again, assuming that the testing volumes are okay, then it's certainly dropping, and the points I raised about the testing volume. And then we did have an increase in inpatient census this week, but it's unclear if it's a one-time event or the beginning of a larger trend. So with that, I'll be happy to take any questions.
Thank you, Dr. Shamiya. Excellent report. Any comments, discussion on the UT Medical Center data this week? If not, again, thanks for your report. And next item on the agenda will be our educational institution presentations, and we'll start with the University of Tennessee. And I believe Dr. Plowman is with us this evening. And I don't know whether Dr. Gregg is. So Dr. Plowman, this may be
I'm on my own.
discussion. Yes, okay.
I'm on my own tonight, so we'll see if I can handle it.
I know-
Thank you, and I have my colleague Jacob Reynolds here with me, who's going to progress the slides. We have the news on our cases. It tends to track a little bit what Dr. Shemaya was saying. If you look at that number, sharp drop, then kind of flattened off. So we've had 1,420 recoveries. As of today, we have 75 active COVID-19 cases. 72 of them are students. 3 are employees. We've had 12 new recoveries today, and then 8 new cases. So if you see in the chart, let's go to the next one. We've added a new metric. So if you go on our website to the way we present our data, we've been tracking new daily cases from the beginning, but now we've got a visualization for that. So here's what you see is the number of new cases. We've been reporting the number of positive cases, which included in it those people who were still recovering. And then we would each day subtract out the recoveries. Now we're making it easier for you to see the number of new cases. So you see, we like the direction of that line. So we're going to keep our eye on it. We also have another sharp decrease has happened among people self-isolating or quarantining. So what you now see as of today, we have 276 students, a total of 313 people isolating, 276 are students, 102 of them are students living on campus in our dorms, 174 are off campus, and 37 faculty. Now, that number is important because at our peak up there, we were up over 2,000 folks self-isolating or quarantining. Now, I also want to talk a little bit about our systematic testing that's now underway. We definitely have seen a huge reduction in the number of people, students coming to be tested. And our systematic testing is going to help us here know a little bit more about what's going on. And I think we'll probably soon start to see, I know we will, the impact of this effort on our overall case numbers as more students are identified. So last week we began our saliva testing in 2 residence halls. We collected 574 samples and tested them for the presence of COVID virus in groups of 5. So that's the pooled saliva. 26 so out of that, so groups of 5, we identified 26 individuals who were reported as positive to the Student Health Center for follow-up, and staff there are getting in touch with the individuals to then do the PCR test, the nasal swab, to determine if in fact they're infected. The students who provide documentation of a positive test result in the last 90 days are not required to come in for further testing since there's no evidence. Now, let me just say, why did I say that? We emptied out a dorm to create an isolation dorm. So many of those students were already tested, so they would not be tested again. We're going to continue to test different residence halls each week. So those 2 residence halls that make up that 574 samples, the positivity rate was just under 4%. That was considerably down from the positivity rate in the Massey dorm where we tested every single person. It was more like almost 10%. So another good piece of data there. The second part of our systematic testing is the wastewater testing. So we've also been continuing that. We have tested 39 buildings across campus. We do this weekly, including all of our residence halls and Greek houses. All but 5 buildings have been tested now twice. The results show an increase in the virus in some locations and a decrease in others. This week, our research team is conducting continuous wastewater sampling to get a better picture of the prevalence of the virus over a period of time. So for example, we're going in and looking over a 24-hour period, trying to look at what is the differences in what shows up in a 24-hour period, just to help us understand what we're seeing in the wastewater sampling. Taken together, the results from all of these strategies, the wastewater, the pooled saliva, and the nasal swab testing are helping us better understand and manage the health of our community. So given that we had 26 look like positive cases that will be receiving the nasal swab, we probably will have 26 kids now going into isolation. We're happy with the direction of this. And we're going to continue to see where it goes. We were able to lift some of the restrictions we put in place a couple of weeks ago. We haven't restricted all of them. And as we learn more from these tests of the dorms, we'll be revisiting some of those restrictions. When Dr. Burks was here, she approved we got to talk to her about our systematic testing plan. She was encouraging. She was in approval of it and our whole approach to testing. So the numbers are going down. We know we're testing much less. So, trying to understand what the numbers mean is part of where we're at. But most of that looks like good news to us.
Thank you, Dr. Plowman. Any discussion, questions on UT's report?
Dr. Gocher, I have just one, and I just want to make sure I understand the distinction. I think I do, but so the pooled saliva is intended to get to the level of an individual student,
Right.
and then test them. But the wastewater is really not intended to do that.
No, it's really to give us a look over time at where the virus is, how intense it. Now, it could, if we find that in one dorm it looks much more intense than another, then we'll go into that dorm next with pooled saliva.
Okay.
But in general, we're going to be using it just from a public health standpoint to see how the virus is looking. It's more like the researchers describe it as it's like a blunt instrument, and then you start narrowing down with the pooled saliva and individual testing.
And just one follow-up question. So for students who are not either in a residence hall or in a Greek house, there really isn't, it's just symptomatic. But if they have symptoms and they want to be tested, that's the only surveillance.
That's correct. And we're encouraging them to come get tested as soon as you feel something, even if you think it's just the sniffles, come get a test. And so that's available to any student. But you're right. So this is only on university housing.
Okay. All right. Thank you.
Dr. Plum, I have one quick question. Is there any update on the collaborative study with UK and
Yes. Yes. So that study is expanding, and we now have South Carolina has joined us, Alabama, and last week we got a request from Virginia Tech. So we're all getting set up with our IRBs. I believe we now will start this coming week. And we will be testing students who were identified as a close contact and have been asked to quarantine. They will themselves do a nasal swab themselves on days, I believe it's 3, 5, 7, 9, and 14, maybe 12 and 14. To try to identify, do we really need that 14-day period? So we're excited that we'll get to that. Dr. Burks said we need 1,000 data points. We'll get to that so much faster with all these schools. And every school is excited because the quarantine is just a big problem for every university. So I'll keep you posted on that as we go.
Great, thanks so much, and thank you for your very complete report. Any other questions, discussion on University of Tennessee's report? If not, we'll go to the Knoxville County Schools report. Ms. Wagner, do you have a report for us this evening?
Yes, sir. Okay, next slide. So these are the number of cases from September the 23rd to yesterday. And for today, it was active students was 42, staff 43. And so that equals 65. Next slide. This just gives you like a bar graph of the number of active students versus active staff. Next slide. So the number of recovered students for September the 23rd through the 29th totaled 268, whereas today, the total number is 160, not the total number, but for students was 164, staff 109. Next slide. This is just a bar graph to show the difference between the staff and students. Next slide. So this is the total number of students in isolation and quarantine for those dates given, the 23rd through September the 29th. And it was 1,002. But for as of today, it was 912 students in isolation or quarantine and staff 123, and the total was 1,035. I know Dr. Buchanan mentioned last week that, you know, they changed classes and things like that, but other factors that impact this is like outside vendors, like, you know, like the Boys and Girls Club or other like daycares and stuff, because some of the staff there might become positive and that impacts the students that attend those places. And they would have to quarantine as well as if they are identified as a close contact. Next slide, please. I think I've, okay, next slide. And this is just a bar graph of, again, of variation between staff and students. Next slide. And these are metrics: student attendance, and custodial support and substitute availability remain in red as they have in previous weeks. Next slide. And this just explains what our metrics mean. Green, yellow, and red. Next slide. So this past week, past Monday, Vine Middle School moved to red, to online learning, and through on Tuesday, September the 29th, and they will return to in-person instruction on October 7th, unless otherwise notified. And this decision was based on the district's metrics of student attendance, like we showed previously. Online learning has been implemented to ensure that students continue to receive high quality instruction. So that's Vine Middle and Halls High School. Halls High School comes back on October the 6th. I think that's the end of my presentation, and I'll take any questions if you have them.
Thank you very much for that presentation. Questions or discussion on Knox County Schools? If not, Ms. Wagner, I've got a question about substitute teacher capability. That's been in red, I guess, for a long time. And the metric, if I recall, is less than 70% availability, or how close are we to improving that, or kind of what would be the status on getting more substitute teachers?
We have hired some more substitute teachers, but we are not close to where we need to be. You know, we've offered incentives and things like that, but people just aren't, they don't want to come right now, I guess, because of, you know, COVID and different things like that, so.
Mm-hmm. Well, appreciate your information. Thank you very much.
Thank you.
So the next item on the agenda is a discussion of some potential metrics by Charity Menifee. So Ms. Menifee, if you have the report for us, please.
Yes, and Roberta Sturm's going to take most of the lead on it. I want to say, first of all, a big thanks to our friends over at UT Medical Center. So this is building off of what Dr. Shamia presented last week with discussion from their team and our team, and kind of handed it over to us. And so we really appreciate the work they did there. I also need to say that Dr. Buchanan hasn't been here this week to see the final version of this. So these are definitely proposed metrics up for discussion. As you'll see as we go through, we're not really close to a lot of those just yet, but I wanted to make sure that that's clear. From there, I'm going to we'll let Roberta present, and then I can chime in if need be. But she, as our lead epidemiologist, is much more capable of going over this than I am. So I'm going to turn it over to her.
All right, good evening, everyone. So these were the proposed metrics for COVID-19 mitigation, and we're using two terms to really define these: escalation and recession. Next slide. And just a reminder, these are the current policies that we're looking at, or I guess that are on the table or for future discussion. 2020-05, the alcohol establishment curfews, social gathering limits, and mask requirements. Next. All right, so looking at the metrics, and we'll get more into detail with these, but the four things that we really wanted to consider was testing volume. We have a recession barrier and escalation barrier for those, and we'll go through that in a second. Positivity rate, the number of new cases based on cases per 100,000 population, the Hertz or THA district census, and then hopefully we'll move toward policy changes. Next. So as far as testing volume goes, the recession barrier and escalation barriers are, for one, 1,700 or greater tests resulted daily average over the most recent 28 days. Now, this was derived using random sample needed to give a normal distribution, and it ranges on about a 90% confidence level with a 3% margin of error. I know that's a lot of statistics I'm throwing out there, but I'm just saying that there is room to evaluate those and, to decrease that, because on a typical day, we don't really have 1,700 tests, as you can see. And then that would be our recession barrier, meaning that we're not seeing enough testing being done. The escalation barrier is if we fall below 750 or less tests for 7 days, an average for 7 days. And so looking at that 1,700 tests, one thing that we were talking about and that Charity mentioned before was that more testing was coming online. And so in order to have an appropriate volume of tests to determine burden, we would really need to see 1,700 or more tests. Do you have anything to add there, Charity?
No, other than, well, I guess I do. And that's thinking of the additional antigen testing and antibody testing, and that will be coming online, and we can figure out how we're going to look at that. But there obviously are questions still about the efficacy of those tests and the way they're used. And so it's just something to keep in the back of your mind as we're trying to navigate how we're managing those results. And but as we make these decisions, just to know that that's out there, something that's going to continue to change and grow.
And I'd also like to add these values are again taken from the Tennessee Department of Health. Next slide. So positivity rate, again, taken from Tennessee Department of Health. You can get these from the website if you just scroll over each of those individual bars. So the proposed recession barrier here is less than 3% daily averaged over the most 28 days, with the escalation barrier in red is greater than 5% daily average over the most recent 7 days. Now, I know there's not a whole lot of room between that 3 and 5%, but these are based on I believe it's the World Health Organization and White House recommendations. Next
and I'll
slide.
add here that we just wanted to go with what the recommendations are that are out there that we could gather from experts across the country and world, obviously, but do feel like these would be up for discussion as well. That 3%, as we talked about last week, I think could be a really challenging one to get to.
Yeah, and with that 3% and 5%, that's somewhere between 14 and 47 cases for our population. Next slide. So for the number of new cases, we applied that. I'm sorry, this is where it would be between 14 and 47 cases. My apologies. So we look at that recession barrier and escalation barrier between 3 and 10 cases per 100,000 residents. So for recession barrier, we would look at that daily average over the most 28 days, and the escalation barrier would be daily average over the most recent 7 days. And as you can see, there have been occasions where we have approached that 10 new cases per 100,000 daily average. So it is within reach. Any questions on that one? Okay, next slide. So using the Hertz region census, where we've had roughly about 120 individuals hospitalized on any given day over the past, it looks like almost month. So we used the proposal was actually a little bit higher than this, but we didn't feel it was realistic for our jurisdiction. So after a much discussion, we decided the escalation barrier should be around 100 patients average over the most recent 7 days, because we're still quite a bit above what was recommended. And I think that was probably in the 70s. Then looking at the recession barrier, we felt 50 patients average over the most recent 28 days was an appropriate recession barrier.
And I'll add to this one. We had discussions between the THA district and the Hertz district. The data, some slight differences in the counties that are involved in there. I believe the Hertz district is larger than the THA district. Dr. Shamia, you have 11 counties in yours, correct?
I believe that's the correct count. Yeah.
And we have 16 counties in the Hertz district, but seem to see less reporting issues from this one. They hammer this one home, and so they update this one daily, and we don't tend to see the drop-offs of them not reporting this data. So felt like this would be a good, stable data set to utilize. And it definitely, all of those hospitals still do feed into the Knox County region. We're still the center for most of those as well. So that's where the difference comes there. This is what you see when I present the benchmark data versus what Dr. Shamia presents each week. They're very close, and the trends tend to run the same as well. It's just, this is just a little bit larger group.
I don't believe there is another slide. Oh, Charity, do you want to talk about next steps? Sorry, forgot about that one.
So what we were thinking was that wanted to kind of present these to you guys today for discussion. Again, I'd really like Dr. Buchanan to have an opportunity to digest this as well. And then from there, we would want to have a discussion on how best to implement those, and if there were changes made, what order of those changes would be made in, and policy discussions and decisions and all of those things. Is kind of what we were thinking the discussion could go today. Probably that would always obviously have to come after settling on the proposed metrics.
Any questions on the metrics, proposed metrics?
Charity, do you know, were you on the call last week? I knew that I had asked Dr. Buchanan this, whether the other metros were doing metrics like this, and if they were, what they put together. Do you know if these are more or less what they're doing, or did that get covered?
Actually, I wasn't able to be on it, so I have to follow up, and I forgot to ask about that. I apologize, but I'll try to ask. I do know that our friends noticed that Memphis, they do have some out that just came out recently, and we got them. Bert, what is it? It was right at the end of the day today, so I don't think either one of us have been able to fully digest what was in there. But there were some quick questions we had, but we want to take a deeper dive in those. But I think theirs are out.
Well, I had a question about comparing these metrics nationally. Are there other similar metropolitan areas, or maybe other metropolitan areas that had a larger caseload or a smaller caseload, and when they released some of their restrictions, or when they added restrictions, were these similar metrics that you've seen elsewhere, or is there a national white paper about this? Just wondering how this is being enacted nationally.
And Dr. Shamia can jump in too, and Bert, I have not had a lot of luck finding that. Definitely, again, I'm excited to be able to take a deeper dive into Memphis and what they're doing, given that they're a larger population, but have also had a larger burden. And see how they're planning to do that. But I have not been able to find any consensus. What we based it on was what we were able to find as far as subject matter expert recommendations. Dr. Shamia or Bert, do you want to?
Yeah, I'll have two comments on that. One is that I mentioned last week that West Virginia kind of at a state level, but managing at the level of individual counties, meaning the state was directing this county to do this and this county to do this, their plan, and you can look that up. It's available. I just went to really their public health website, but they, I haven't been to it in 7 days, but this is the approach, very similar conceptually metrics to what is done here. The other thing is that I looked at the Shelby County, it's Health Directive 12 from Shelby County Health Department, and it's dated September 22nd, and it's accessible through their public health website. But they really, notably, and it's even the timing is odd, that they were kind of working on this in a similar way. They don't have a board of health, their structure is different, but they have a table of essentially improvements and setbacks. And while it's not identical in terms of which metrics were chosen, the spirit of it, the essence of it is very similar. And so if I understand correctly, they've really only been under it for a short period of time, but I haven't had time to really study that either. But these are, it's not like these types of metrics were just pulled out of the air. I mean, this is a lot of what the White House Task Force and others have used to track data. I do have a couple kind of thoughts about how the metrics might be used, but I want to make sure that topic is closed before I move on.
Any other discussion on the potential metrics? Again, Charity, I think we probably need to let this go through channels with Dr. Buchanan so she's aware of it as well. I don't know whether it is time to take any firm action on that tonight, but
we'll be sure to get it out to you all as well. We didn't, we're hoping to get it out before today so you could look at it, but things just didn't work out. It was ready pretty late in the day. So
yeah, we know this is evolving, so right. Any other discussion, questions, comments?
So
if not, yes.
Well, I did want to just bring up one point about the, one thing we'll have to be thinking about is whether it's 3 metrics or 4, is the interaction between them, meaning that if you're using multiple, then what if you've hit 2 of them and haven't hit the other 2, whether it's escalating or de-escalating. And then another thing would be, from a hospitalization perspective, if you really hit the other ones perfect, then you shouldn't necessarily get in hospitalization trouble. So the hospitalization one may almost be more of a, whoa, this did not go according to predicted plan, and we're on our way to being underwater, so therefore we would react. And so I think that we need to be thoughtful about those things. Another thing is just there's that tension between the recommendations and what may be realistic. And so I think it's important, if we take this route, that we find that balance between those those factors. Thank you.
I totally agree with everything Dr. Shamiya just said. The other thing that Catherine asked me to just mention is they're working on still the online forum that for you all to be able to perhaps discuss and send ideas back and forth. And so hopefully that'll be up between, since we don't have a meeting next week, we'll be able to have it up there and you guys could have discussion publicly. So you can be working on this between now and next meeting. So we're going to do our best, hopefully, to have that go. And there's just been some issues and delays, but hopefully that'll be going soon.
That would be very helpful for us to continue discussions because of the sunshine provisions. We have to be careful about discussions. That would be a way we could do it, and it would be out in the open for everyone. It'd be great.
Yes, and again, on that front, our team, our EPI team and the data gurus at UT spoke, but we've made sure to keep the board members out of that discussion this week. So just want to be clear on that as well.
One other thing that might be useful for discussion, since the governor has for 89 counties sort of released a lot of the mandatory requirements for either mask, social distancing, et cetera. So in 2 weeks may not be enough time to really reflect on this, but and not all counties via their mayor are releasing some of these requirements, but it might be interesting to look and see what caseloads are versus releasing restrictions or keeping restrictions. Might just be interesting to see because that data will be around us, at least in some of the counties.
That's a good point.
Any other questions, discussions on proposed metrics? If not, the next item on the agenda is COVID-19 face covering regulation, which is 2020-1, again for review and discussion. Somebody want to lead the charge? Charity, are you online? Is there any other
I'm sorry.
information? I'm sorry. Is there any other information from Knox County information about 2021?
Yes, sorry, I was trying to get to it. Okay, we don't have any on the mask, so pretty much steady stream. I can speak to the other one. I pull up the information I received on that, but no, everything's pretty much holding steady for us on that from our complaint side of the house for the mask.
Any other points to discuss, comments, general discussion from board members?
I'm not sure how many folks watched the county commission meeting the other night, but I know that Dr. Buchanan reported there's been no citations, no arrests, no, it's basically just been education as we intended.
So I'll take a quick moment of personal privilege to thank Dr. O'Brien and Dr. Buchanan for their efforts at that meeting. I had said I might be able to go. I ended up with a facial fracture trauma case, and I finished about 8:30 at night, and I thought to myself, surely it's over. I'll see the rerun of this, and it wasn't. And I actually watched it until the very end at about 1:30, and it was interesting. I had a short night, but I'm sure Miss Rome even had a shorter night than I did. So that was a long meeting, and there was, a lot of contested opinions and such, but interesting to watch. Ms. Rome, any comments about that meeting from your standpoint? It looked like quite an occasion.
Well, it was interesting hearing the public forum views from so many citizens, but that's really, yeah, it was long. It was a long meeting, but I did hear some interesting points brought up that I know I hadn't considered, and so that's where I'm at with that right now.
Great, thank you, thanks. So any other discussion about 2020-1 and so the sunset on this regulation is?
There isn't one. I think we have to actively repeal it.
That's correct. There's not.
So, and again, when we set up metrics, we'll have a very clear understanding of when that may be able to be lifted. I know that our citizens many would very anxiously await the lifting of that regulation. But if we have good metrics to base that decision on, then everybody will know when that's going to happen. Any other discussion on 2020-1 from the board? Knox County Health Department, we're all good. If we get discussion completed, we can go to the next item on the agenda, which is the curfew regarding sale and consumption of alcoholic beverages in certain establishments, which is 2020-5. So that's up for general discussion from the members.
And I can jump in on this one. I did have the update from 311, who takes a lot of our complaints. They did receive, looks like 7 to 8 specific location complaints, and then some general area complaints, you know, the Cumberland Avenue area and that kind of thing. And then Knoxville Police Department has said that they've issued no citations. They've been focusing efforts on Cumberland Avenue. They've been very compliant, even after the ball game last week. And they're hoping that things will go that way this week as well with the home game. And again, they're focusing on education, definitely. And then our team as well, with complaints that we receive. No citations issued, and it's again pretty steady trend, and definitely focusing on education. But I will say that I was happy to hear what KPD said as far as seeing how things went last weekend, given the game.
So, question to kind of further clarify that in terms of education, is there a sense from either Knox County Health Department or any board members that might have knowledge of this about how successful those educational efforts are, whether they are accepted and used well by the owners of these restaurants and establishments? Are we making a positive impact by that education? How's that?
Yeah, that's my understanding from the reports that we received, that it's, you know, it's going pretty well thus far. So I haven't heard contrary from any of our sources that we've spoken to from 311 or KPD or from our team.
I'd like just to say something about, I've talked to one of the major merchants who's been involved with the process on the Strip. And I've got to hand it to the business owners, at least in the city that I know of, and a fair number across the county have really bent over backwards to work with us, to educate their staff, their patrons. So I've got to say they've really done a good job. And in my discussion with this gentleman, I told him that we usually want to look at these regulations running about a 28-day period to see how, you know, if we need to continue them or not. So we're at 14 days on this, and the only reason it's 14 days, there was a typo mistake at the time that we implemented this, that it should have been 28 days instead of 14. So we would have to correct that tonight. But again, I want to say thank you to the business owners. Yes, there's a few outliers. I know of one major entity that is outside the city of Knoxville that's been noted. And, you know, again, that's going to happen. There's going to be folks who say, I just can't do this. My finances don't allow it. And they're not going to follow. But everybody that I've talked to, and talking to KPD, to Chief Thomas, they say it's been really impressive what our business owners have done over the last 2 weeks. So kudos to them.
Dr. Gocher.
Yes.
So just one thing I would add from a data perspective, and it gets back to Dr. O'Brien's comment that the original intent had actually been to have been 4 weeks as opposed to 2. But the data that I showed, at least today, there is a little bit of a disconnect. And of course, the trending is not always going to be perfect. But one possibility in that increase in census that we saw is that's just the natural timing and evolution. And that because we've seen cases go down, that we'll see census down, and everything will be down in 2 weeks. On the other hand, I don't know that I'm really at peace saying that that's precisely what's going to happen. I'm watching the census piece very closely. And so I think whichever way it goes, there'll be significant clarity. Well, as significant as you can ever get clarity in COVID-19, but I think there'll be potential clarity in 2 weeks on that.
No, very good. One other, just kind of a real shout out to a large number of small business owners in the community that took time out to send us a kind of a large group letter thanking us for what we have been doing and pledging to sort of stay the course with us, even though personally I know it's got to be difficult for our small business owners. So that, you know, in light of a lot of the controversy over the last couple of weeks, that was really a breath of fresh air. So appreciate their input. That was great.
Yeah, I'd like to say I also really appreciate the encouragement, the effort. We have in all the weeks we've been meeting, we recognize almost, I think, every meeting, the sacrifices people are having to make, families, businesses, the mental and emotional toil it takes. And we recognize that we're people, we have families, some of us have small businesses, etc. We understand. It was really nice to get that letter from small businesses. I think the last count was there were 90 small business owners, local businesses that had signed that letter. So, and thank you to all our fellow citizens who make those sacrifices and efforts. We get it. We really do.
And really, we appreciate all input, because we know not everything's going to be positive, not everything is going to be negative, but we just appreciate people showing enough concern and enough passion that they want to share their thoughts with us. Appreciate all of that. Any other discussion on 2020-5?
Dr. Gosher, I think the point made about the date needs to be clarified, if it's going to continue or not tonight, if I'm not mistaken.
Make a motion that we add 14 days to the order and reevaluate it as we had originally stated. It was supposed to be a 28-day order. It was I did not catch, and I would ask consideration for that.
We have a motion. Is there a second?
Second.
So we have a
Dr. Gocher, you're off.
Sorry. So we have a motion and a second to basically take care of a bookkeeping change to go with our original intent of a 28-day cycle for Regulation 2020-5, open for discussion.
The one thing I'll say is I'm hoping that'll be it. I really hope we can see what the cycling has done with the disease, and we can drop this, because we do not want to ping pong our public. We don't want to drop it and then bring it back. So we just need to encourage those 5 core actions, everybody. Please, please, please. And if we can do this for 2 more weeks, our numbers look good, we can let this thing sunset. And that's the hope.
And for clarity's sake, from 2 weeks from tomorrow, when it would sunset, what it is would be October 15th. Just want to make sure everybody's clear on that.
Which would be the date of the next meeting. As we.
It'd be the day after the next meeting.
Yes, it goes by 12:01. So we had it tonight at 12:01 on October 1st. It will be 12:01 on October 15th.
Right. Any other discussion on the motion? If not, sensing you're ready to vote, Narda, if you'll have a roll call vote for us, please.
Narda, are you there? If not, I'll do it.
Okay, thanks, Charity.
All right. Dr. Drake,
No.
Dr. Gocher,
Yes.
Dr. Hertz,
Yes.
Mayor Jacobs isn't here. Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Souza,
Yes.
Ms. Wagner.
Yes.
Dr. Buchanan is not here. Seven to 8 in favor of the proposal, or 7-1. Sorry, I added. Public math should not be my thing.
you have approved 2020-5 as amended. Any other discussion on 2025 before we leave that topic? If not, the next item on the agenda is COVID social group transmission suppression. That's 2020-6 for review and discussion.
Do we have any idea if there's been any, I guess, report citations, anything associated with this?
There have been zero reports or zero citations with this from us or any of our partners that we're aware of.
I haven't heard of anything or any problem actually. So that's, again, this is one of those things. Do we want to go our full cycle, or do we want to let this one go or not? So I think we need to talk about that.
Was this one up for just 2 weeks or 4? Just 2?
This is on for 2 weeks.
Right.
This one would be tomorrow, yeah.
So one of the, Dr. O'Brien, I think one of the intents was, or part of the intent was that the large gatherings right in front of a business waiting to get in without social distance, very close together. And so, you know, to what extent that it's been effective in that regard, it kind of goes along with the other that we just extended. So just from a logical standpoint, again, with your expressed hope that the first one would not need to be renewed and could be sunset, I'd hate to achieve part of the hope or the intent and not achieve the other part. Then we may actually undermine the whole plan.
So I guess one point to maybe discuss, and I'd ask for members from the health department to help us with this. As far as we know, there have been no ongoing complaints that this has been a problem. So it may be that the education of the establishments that were known to have this happen has occurred. And that problem has been corrected. And gosh, it'd be really nice to have Chief Thomas here to give us sort of an update. I know Dr. O'Brien went out on a mission to check into this, and we all saw it in the newspapers a few weeks ago. And I'm just not advocating that we go out on any sort of mission to even look at this stuff, but just wondering if the problem has basically been solved just by educating those 2 or 3 or 4 places where that was sort of an egregious problem.
I can just speak to my conversation with this business owner of the establishments on the Strip, that I think they, as the business, understand it. The only outlier are the students at this point still. And on their property, in what they can control, it sounds like they are doing that. Now, there are other areas I've been told, I have not personally seen outside the city, where there have been large gatherings inside establishments. I cannot, again, I haven't seen that. But we also haven't heard of any contact tracing at this point to any problem there. But I agree with Dr. Shami. I think the probably prudent thing would be to let this go for 2 weeks also to finish the 28-day cycle. And then if we are good, let both of these expire at that point.
Questions, discussion on 2020-6? Do we need a motion to continue this? I think we do.
Yes, sir.
So we've had general discussion. Is there a motion regarding 2020-6 and a second?
I'll go ahead and make a motion for extension till the October 15th, 12:01.
Do we have a second?
I'll second.
We have a motion and a second. Further discussion. Hearing none, are we ready to vote? So either Charity or Narda. I see Narda's mute went off. Narda, welcome back. So let's go through a roll call, please.
Okay. Dr. Drake,
Yes.
Dr. Gotcher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs is not here. Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
and Ms. Wagner.
Yes.
Passed 8-0.
Thank you. You have adopted 2026 for the next 2 weeks. Any other discussion on 2026 before we move on? If not, the next item of the agenda is the Knox County Commission Resolution, which is R20-9-907. General discussion. If not, I may ask Mr. Sanders to give us maybe a brief review of this and how this affects what we do or any implications for what we do. Mr. Sanders.
So I think the simple thing to say, and I believe this was spelled out pretty well at the commission meeting, is that the resolution that was passed Monday night does not affect this board in any way. It is an aspirational statement of the county commission, but it does not actually impose anything on this board, nor does it affect the regulations of this board.
Comments, discussion?
I would just say, having sat through 8+ hours on Monday, that is exactly what I learned.
And watching from my home, I agree.
I see you're nodding in agreement. It was a long evening.
I
Any
second,
thoughts,
yeah.
discussion about the whole meeting itself?
The only thing I'll say, having sat through what we sat through and what you saw, is that, there was a lot of public comment. I appreciate, the public commenting. Some of the comments were well-founded, based on good fact. There were some that weren't. Our job, again, that we have to tell the public is we're here to do the best we can with the information we have as healthcare professionals and others to do the best for Knox County. We're not trying to do anything else. We're not doing anything political. We are dealing with public health, and we'll continue to do so until state law says otherwise. And we will do so until, when this pandemic's over, we'll go back to our regular deliberations. But until then, we're going to do what we can to keep as many people safe in this community.
Thank you for those comments, Dr. O'Brien. Any other discussion regarding R20-9-907?
This is Maria. I would like to once again thank Dr. O'Brien, Dr. Buchanan, all of us who hung in there and watched, listened to the public forum at the beginning, in the middle. Was there any at the end? I think it was just the beginning and the middle of the meeting. And Ms. Roma for hanging in there. That really showed some fortitude and some dedication. What I would like to address just briefly is the lumping of these two major concepts, unelected and unaccountable, because I heard those themes over and over again. And I would just like to go on record and say those are two very different things. We are unelected. That is true. And the research that I did, someone helped me with last week, was there are no elected boards of health in the nation. And there's a reason for that. And Dr. Gotcher, I believe you've addressed that in the past, why in general boards of health are not elected, so that we don't get pulled into the political fray. But that is something very different than unaccountable. And we, as I mentioned last week, we are accountable to our professions, to our certifying bodies, our oaths. The state boards to which each of us, have to comply with the law. So we are held accountable. And in fact, the county commission itself vetted us after each of us have, or anyone filling our role has to be one, nominated by their professional organization, and then we have to be vetted, and we were vetted by the county commission, and then they voted to allow us to be on the board. They appointed us. So there is a level of accountability, and if we're not, that's what I want to say is we are accountable, and that is different than being unelected. So I think it's important for us to continue to clarify that to people who confuse the two and think they're the same. They're not. And we hold ourselves to high standards, and we have to. By law, each of us have to be held accountable by our professions and in the laws that govern us.
So I've got maybe a brief comment. This is just maybe kind of a personal opinion about future directions for the board, probably over the next year or so. Mr. Sanders, you can correct me if my legislative or political thinking on this is off, but it occurs to me that this is something that might be changed either by the governor with an order, or it might be changed by the legislature. But what I would say is that there are different states that do this differently. And the state that I grew up in, Texas, has got the governor primarily responsible for regulations that are much more restrictive than what we have in Tennessee. But somebody has to step up to the plate, be that the governor, be that the legislature, be that the county commission, or us. And a failure to have anybody step up to the plate is certainly a recipe for disaster. So in the absence of other people stepping up, that's how we got where we are.
Dr. Gocher, I'd like to follow up on exactly on what you said with a few additional thoughts, because I've reflected on this a decent bit in the past week. And this also, Ms. Roma, I wish somebody had given me a little bit of an orientation as to what this was going to be. We've kind of been figuring this out as we've gone, but I think Dr. Gocher gave me the perfect opportunity. And essentially, the position that we're in is that I view it in three categories. And the idea would be that if we as a board just dramatically are over conservative and overreact, and the pandemic from a health perspective goes okay or goes well, we'll be criticized for overreacting. If we get it just perfect, whatever that means, and I don't know exactly that you'd know it in the time, but if you get it just perfect and the pandemic goes well, we'll be criticized because it will seem that we overreacted. And then if it doesn't go well from a public health perspective and the wheels come off, we'll be criticized. And so I think that's the environment that we're in. And as Dr. Gocher mentioned, there needs to be someone in that position. And Dr. Hurd, I absolutely agree with you that we are accountable to all those things that you described. But what we also are in a position of is we increasingly are going to have various people or groups of people giving us strong urging to do certain things, but not really feeling the entire weight of the situation on their shoulders in what I described as what is fundamentally an untenable, essentially no-win situation. So I like the direction that we're headed with the metrics. I'm equally hopeful that this, for example, the blip we've seen in census is going to come down and follow the data trends. But this is a difficult and somewhat, the rhetoric that we're on the receiving end of is not something, quite frankly, that I was prepared for. And so both for your benefit, but just for the group, and Dr. Gocher, I took that opportunity because you gave me the perfect opportunity to do so. But I mean, that's kind of where we are. We've been given a strong suggestion or a suggestion from County Commission with an 8-3 vote, but it's still really on us to look at the data and try to make these scientifically driven decisions. And I think we're all committed to do the best we can with our training to do those things and to represent, Ms. Roma. Now we've got a broader group and to represent those people that are giving us their opinions.
I'll say one thing real quickly. We do read the emails still. We get lots of them. And some of them are very helpful. Some of them are supportive and some of them are not. And so, for those who don't like what we do, please be patient with us. Please don't do things that, tell us things that aren't good to help the process. We want everybody to be positive with this. We want to work together. We do read and hear what you're saying, and we just want things to go well for everybody.
Thanks for those comments. We have, as you know, done the public forum discussion at the beginning of the meeting. So the next item on the agenda, if there's no further discussion on that resolution from the county commission, is other business. So is there other business to come before us this evening?
Dr. Gocher, I have one thing. It really is just something I neglected to mention in my presentation because it was the specific email question that had come, and that had to do with the ICU, what's happening in the ICU percentage, and how is that relating to our overall hospital census. And essentially what we're seeing is the overall census goes up, the percentage of people in the intensive care unit, relatively speaking, goes down. And so it most recently, I believe that THA data, it's about 27% ICU, but it tends to, when we have a census about like this, it tends to be in the 27 to 30% range. But I bring it up specifically to Dr. O'Brien's point, is that it was a really thoughtful email asking that question, and just totally skipped by it in my presentation.
Thank you, Dr. Shamiya. Along those lines, and I'll mention this just briefly, I assume that everyone has received, and I know I received some emails from one of the, I'd say, prominent business leaders or prominent business thinkers in town about several aspects of sort of the business side of our decision making, and came up with what I thought was a pretty good idea, but I would need to start the process going on this probably through Knox County Health Department. And that is, when we have a proposal, if it is possible to have a dollar impact or dollar notation on that. This is done for all basic legislation that goes through the legislature. Now we are passing regulations, not legislation, and those can be crafted with a lot of background help. But that would be really helpful in the total picture if we had that. It might not be. I mean, if you look at something like a masking regulation, trying to figure out if there is in fact a dollar assignment to something like that might be really difficult to obtain. Maybe it is. I don't know. A dollar assignment to something like a closure time for restaurants and such might be easier to get a dollar assignment on that. But I bring that up for just some general discussion because it seemed to me to be a very thoughtful comment, and it might be conceptually difficult, or it might be easy for a group of the size of the health department to come up with those figures. Thoughts? You all may have gotten that email, and I studied it quite a bit because I thought there was a lot of meat in that.
I can speak from our perspective. We don't have an economist on staff that could help with that. And so in the past, when we've done that, we have asked our friends at the University of Tennessee to assist with that, with their expertise. And I will say that it takes some time. So the timing could be an issue, but we could ask if we could. It might be a team there that needs to help with it. And then I can't speak for them on how fast they can turn it around. I could say in non-emergency times when we've asked for that type of data and support, it's taken a little while for them to be able to pull it together. But it's not in our wheelhouse to be able to do it in-house.
Thanks for that information. Any other discussions, any other business that needs to come before us this evening? If not, again, thank everybody for their participation and their thoughts and getting us through all this. If there are no other items to come before us and other business, we will take a motion in a second for adjournment.
Real quick, I just want to say, to make it clear, because I don't know if I did, we will ask and see if we can get some folks to help.
That would be great. And again, that's a point of general discussion, and maybe next time we meet, or maybe an email out to everyone and, kind of give us an update and see what is possible. I think that would be a valuable addition to our deliberations.
I make a motion that we adjourn.
And a second, and by affirmation, all in favor. We'll see you all in 2 weeks. Stay safe. Thank you.
Today on This Old House, some 100-year-old subfloor becomes a pantry door. I'm going to help the next generation of landscapers restore a historic garden.
And radiant heating is going to make this garage toasty warm.
What happened to all this plumbing here?
I've never seen anything like this before. There's already rot going on in that trunk.
So what have you found up here?
Well, a bit of a surprise. It's really the classic plumber's lament.
Nice. Here is right on. Family that paints together stays together. Nice job, guys.
Where will a slab like this be used?
The money's in the detail.
Oh, look at that fit. That is beautiful.
Ready to get to work? Yeah, let's go.
Hi there. I'm Kevin O'Connor, and welcome back to This Old House, where we are working on this modest home in Newton, Massachusetts, for a young couple who's trying to make more room for 3 generations of their family. Now, the budget is tight, so they're trying to save money wherever they can, and one of those places that they could was here in the dining room. When Tommy and Charlie pulled up the strip oak flooring, they found a subfloor down below that was original to the house and old growth timber, and that gave them an idea. Right here is the new pantry, and you can see it is framed out for what was going to be a pocket door, a door that would be hidden half of the time. But when they found that old growth timber, they had an idea. What if they built a barn door that would be exposed all of the time and the family could enjoy it? Well, that's exactly what Charlie's working on right now in his workshop. Hey, Charlie, how are you?
Good, Kevin. How you doing?
All right, so this is the stuff you guys found, huh? Well, I love it. What do you think it is?
I think it's old growth pine, and the homeowners want a rough side facing the kitchen.
Yeah.
And I think these boards are going to be perfect.
All right, so what are we doing today?
I'm going to finish taking the cut nails out. You want to give me a hand?
Yeah, sure. You got some old remnants in there. Get some tools. Oh, yeah, you can see them all throughout, right?
You can. Just give them a good little whack, and then we'll flip them over and pull them out.
Probably the original cut nails, right?
Oh, yeah. Well, these old cut nails held this floor down for a long time.
Yeah, that. That's an old one.
Well, these boards have a finish on one side, rough on the other. We want to save the rough side, and we want to clean up the finish side by taking about a 1/16 off with the thickness planer. We're going to clean these edges up with the joiner. Let's lay these down rough side up.
Particular order. How does that look to you?
I think it looks great. What do you think?
Looks good to me.
All right, we're going to put these together with a series of floating tenons. We're going to space them about every foot, and then we'll glue them in place, and then we'll cut the door to length.
All right, I'll mark them.
I'm going to put the glue in the mortise because I don't want any glue on the edges. And you want to follow me with the tenons? And let's start tapping them together. Nice and even. That's it. Let's square up one end of the door and then we'll measure it to cut it. All right, let's cut this door to length. You want to mark it 6, 7.5. The last thing we have to do is put these top and bottom rails on. We're going to glue them in place and then fasten them with cut nails again.
Is that the side you want up there?
Yep.
Okay.
Want to hold this in place while I tack it?
Just make sure. Okay, it's over there. Hang on 1 second. Yes, that looks pretty good there. That is looking pretty good, Charlie, huh? Not too bad.
Looks good. All we need is some exposed hardware for this door to slide on, and we're all done.
Want to tackle all your home improvement projects with confidence? Join This Old House Insider.